Hello, I'm Dr. Omar Bey of OBHealthy, and this is the Physicians Lounge. It's where we come together as physicians, and just like in the doctor's lounge, what we do is we just discuss medicine, but we discuss medicine in a way that you guys out there can understand what we're talking about. So that's important. That's important. There are two basic, I should say, very important things to us as physicians. Number one is this webinar is to improve the health of people of African descent, number one. Number two is to encourage young black males to go into medicine because right now we have a shortfall. It's going to be a crisis pretty soon. So we encourage any black male out there that's thinking about science, put medicine at the top of that list and become a doctor because you can do it. Okay. Our webinar is every second Saturday at 1 o'clock. Okay. And if you want to check out the prior webinars, all you have to do is go to OB Healthy, click the doctors tab, and you'll see a camera there. It'll take you right to the prior webinars or our YouTube logo anywhere on the website. Just go ahead and do that. Okay. Remember to subscribe, please, to the YouTube so we can continue to bring this to you. Very important. Don't be afraid to type in your medical question. I mean, we're here for you. We're here to truly answer your questions. We have a topic that we're talking about, but any question is good. Just and no questions too small or too large. Type in your medical question. I'd like to thank OB Healthy for allowing us to bring this webinar to you because without them, it would not be possible. The most important thing that I can say today is please do not change any aspect of your medical care before you consult your physician because only your primary care doc, believe me, can best take care of you from a medical standpoint. All right. Our docs will be signing in. We have several of them here today. Our topic today is weight loss and weight management, and we have the perfect person to go over this, Dr. Ramik Hunt. Believe me, the brother's bad. He's here, and we're going to talk about all aspects of that. But before, I'd like to introduce our panel. Dr. Lee, can you introduce yourself and tell us about yourself?
Sure. Good afternoon, everybody. My name is Dr. James Lee Jr. I'm a second generation orthopedic surgeon, board certified. I'm glad to support and be here today.
All right. Thank you, Doc. Dr. Court, you are
Good
with
af-
us this morning or this
yes,
afternoon.
I'm happy to be here as usual. I'm Dr. James Cord. My practice is located in East Orange, New Jersey, but I only treat adults, specialty internal medicine.
All right. Thanks, Dr. Court. And Dr. Patrick Anderson, my idol. You know, Patrick, I was making rounds this morning, and one of the patrons, oh, hi, Dr. Anderson. Go ahead, Patrick. How you
Yeah,
doing?
yeah, I'm Dr. Anderson. I'm glad to be here. I look forward to the second Saturday of every month. I'm a gynecologic oncologist. I practice in South Orange and at North Beth Israel Medical Center in Newark.
All right. Thank you. Thank you. I always tell them, Patrick, I have more gray hair, but you look better than I do. You're more handsome than I am.
Listen, but my patients stress me out more than yours do.
All righty. But Patrick, your voice is just a little blurred. I don't know if it's the distance from the computer but it's just a little fuzzy there as far as your voice. I'd like to correct that as possible.
Is it any better now?
A little better. We can understand you, but every once in a while the words get a little fuzzy. We can't. Hard to understand. I'm not sure why.
Okay. I may break for a quick second and use a
Okay.
different setup.
Okay, no problem, no problem, Patrick. All righty. So Dr. Ramik Hunt is with us today, and I'm so proud of him. I'm proud of all what he does. He's out there in the community doing so many good things for our people as far as medicine is concerned, and so proud that he would take the time and come on and be on the webinar today. Ramik, how you doing out there?
I'm good, Dr. Bay. How are you?
I am so good. I'm so proud that you would take the time to come and be with us. First thing I'd like to do, as always, I like you to introduce yourself. But in introducing yourself, tell us, why you went into medicine, how you got there. It's so important for our young people to know, how we did it and that
Yeah.
they can do it. So tell us who you are, what you're doing out there, and I'm just looking forward to hearing about it.
So thank you again. My name is Dr. Ramik Khan. I'm a board certified internal medicine physician and a board certified obesity medicine specialist. And my story goes way back to Seton Hall, and you were one of my inspirations, Dr. Bay, and helping us, me and my two friends, Dr. Sampson Davis and Dr. George Jenkins, to become physicians and dentists. And we made a pact to become doctors. So we went through high school together, college together, medical and dental school together, and then we've been just together doing things in the community and throughout the foundation as a collective. And as an individual, I practice internal medicine. As I mentioned, I started out at St. Peter's right out of residency. I ran the clinic for St. Peter's for patients who were uninsured or underinsured right out of residency, and then from there, because I was I was a professor of medicine at Robert Wood Johnson, and so when that hospital split from Robert Wood Johnson, I went to Princeton because they still had an affiliation with Robert Wood Johnson. I still wanted to teach, so I stayed on staff at the medical school and moved my practice to Princeton. And so I've been in Princeton for roughly about 20 years. And, I'm the only Black male physician internal medicine in the area, in the hospital, at least at that particular, I won't say the area because Trenton is in the area and we do have some great physicians there. But at my hospital, I'm the only one. And so I first started out just doing internal medicine, but I wanted to have a specialty. And one of the things that the people joke all the time, and they go, you doctors, all you do is write a prescription. You say you got this ailment here, here's a prescription. And you got that ailment, here's a prescription. And so people always joke and say that all we do is write prescriptions. And and then people always say, you always blame everything on my weight. And so I had a patient, and we can get more into this, who inspired me to look into obesity as a disease. And I then started researching a lot and then got more focused on obesity research. And then I went and got board certified. And 10 years ago, I started a comprehensive program, the only one in the area, actually, obesity medicine clinic in Princeton and in the surrounding areas.
Excellent, excellent. The thing of it is, and I agree with you as far as our people are concerned. I think I don't know if we have a body image that how we view our bodies is different than maybe other cultures and stuff like that. But we definitely have a body image of, and I hear this often and with some of our patients is, I don't want to be too small. You know what I mean?
Oh,
Being
yeah.
small is like being sick, and
Yes.
you know what I mean. So it's kind of in our culture to a certain degree to have weight on, but sometimes obviously we overdo it a little bit. I think, but weight is a very important thing to us. Um, let's just when you start talking about this, why don't you give us some idea of what your day is like? You know what I
Got it.
mean? Uh, as far as the type of patients you see, how you kind of handle different things, where do you start in as far as helping someone lose weight, those type of things, just some basic stuff, because I think the basics are so important before we get into the details.
Yeah, I
Yeah,
agree.
Omar,
So,
before Dr. Hunt starts, if I may just ask him, if Dr. Hunt, Ramik, could you just give us some basic definition of the definition of obesity, overweight, so we can have a framework or some guidelines as to how to come at you with some questions.
got it.
You
I
stole
think
my question, doctor.
that's a great place to start. Let me just give a real quick intro about how my clinic started. And I briefly started to mention this woman, a Black African American woman who I took care of her whole take care of her whole family. And she came to me with her blood pressure being elevated. and she was gaining weight, and we put her on a blood pressure medicine to control her blood pressure, but her A1C, her sugar number, she was pre-diabetes. I know we're talking to an audience, so I want to make sure I don't get too technical. And I mentioned to her that, you know, her sugar was going up, and along with her weight. And so and we talked about her weight being something that she should work on, and that would help with some of these other medical issues. So she vowed to help work on it, and she was trying, but she was having difficulty losing weight. And so then we decided that we should probably start her on a medication for her sugar, because her sugar had gotten to a point where her A1C, her sugar got to a point that we needed to control it. And so she was very resistant to that. And she said, look, doc, please give me another 3 months, check the numbers again, and we can discuss it then. But I really don't want to go on any additional medication. And so lo and behold, 3 months later, she came back and she had gained 5 more pounds. And I'm like, you know, we're at that point, you know, your sugar went up even more. And I don't know why I said it, and I wasn't trying to be mean, but because I took care of her whole family, I knew her family dynamics, and I asked her, I'm not a pediatrician, so I didn't take care of her kids, but I took care of her husband and another family member. And so I asked her, did her kids have issues with weight? And then she just started to cry. And the reason she started to cry, she told me later, was because her kids, in fact, had issues with weight. And that week before, her son's pediatrician had told her that he also had prediabetes. And she felt that she was responsible for basically making her kids unhealthy, because she bought the food, she cooked the food, and she was making her kids unhealthy. And then she left the office that day. And I didn't have the heart to write a prescription for a medication because she was so emotional. But long story short, about a year later, she was 100 pounds down. And she said to me, thank you. And I was like, for what? I didn't do anything. I didn't give her any instruction. The only 4 words we learned in medical school about obesity was eat less, move more. That's it. Right? And so that's not instruction. And we blame people. We finger wag at them. And so I said, well, thank you, but you did the work. You put in the work. You did what you had to do.
Yeah.
She said, no, but that conversation that we had really kind of stuck with me, and it made me do what I had to do. But I felt inadequate, right? Because I really just told her to go do something, get your health better. But I'm used to being able to help people and guide them along the way. Here's a medication. Let's do this. Get your salt down. Do 150 minutes of exercise. All these different things. I'm used to helping, and then you come in every 3 months. We check up on you, and for this, it was just like eat less, move more. And so I actually Googled, like, is there any specialty in obesity? And something popped up, and I went to the conference. It was in Austin, Texas. And I tell you, it changed my life, because I'm sitting in this audience, and the presenter said, blah, 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 and we have to work, and we have to let physicians and patients alike know that obesity is not the patient's fault. And then everybody's shaking their head, and I'm looking around, and I'm like, hold on, no, of course obesity is the patient's fault. We know this. But everybody else is shaking their head like, yeah, that's right. And it got me to get into the science of obesity and learning about set points, and not just your weight as a set point, but other set points in your body and how your body regulates these things. And that I felt like I sipped the Kool-Aid. And I was like, oh my God, when I learned all this stuff, I ran back to my office, and I'm like, I gotta do. And I said, you, my patient, we're gonna get to work. And then we got to work, and I started teaching my patients about the different macronutrients and how the physiology of how they affect your body, and how that can, if you eat properly, it can then help you burn unhealthy fat, and so on and so forth. And then at the time we knew about the hormones, but there weren't too many medications out, but there were some on the horizon. And we were talking about the gut hormones and all these different things. And I was one of the first people to start using these medications to help in weight management. And at the time, people thought I was a little bit of a quack because I was on this 10, 15 years ago when people
Mhm.
weren't using it too much. So I'm really excited when I can get people to a healthier weight. They lose 100 pounds, they lose 150, 200 pounds. And I can say that I was instrumental in working with them and helping them along their journey. And
Mhm.
one of the first things that I do when they come to my office is they come in and the first visit is a longer visit. It's about an hour long visit that we go through what the program is about. And I give them a brief overview of the physiology of obesity and why it is. And one of the first things that I say to them is obesity is not your fault. It is not a willpower disease. And we're going to talk about why that is.
Mhm.
And you should see the weight that is lifted off that patient. And
Mhm.
then we can get to work. Because now they can like, okay, I'm all ears. And then
Mhm.
and that's kind of how I start my visit. And we talk about the science of obesity. We talk about how the body has set points. And we have multiple set points, right? Our pH balance, our pH is set at 7.40. So if you deviate from 7.40, your body will bring you back to 7.40. You don't have to willpower your way to 7.40. Your temperature is set at 98.6, so that if your temperature goes up, you sweat. If your temperature goes down, you shiver to bring you back up to 98.6. You don't have to willpower your way back to 98.6. Your body also has a set point for your weight. Shouldn't say weight. I should say your fat. I shouldn't say fat. I should say your calorie. Maybe I should say it better. Your energy storage. And where's your energy stored? It is stored in your fat cells. So your body has a set point for your energy storage. And this goes back thousands and thousands of years genetically, because our body in the humans that are alive today have been genetically, we are good storers of energy. Why is that? Well, back in the day, some of us, not all of us, thank goodness, but some of us had to hibernate in the wintertime. And during that time, we had to stockpile food, and some of that food would go rancid, get spoiled. We wouldn't store enough food. And then, so basically, when the springtime came, the only people that made it out were people who had a little extra, little extra tummy. Skinny
Mhm.
people didn't make it. And so we were genetically selected to be good storers of energy, which is why we have shows today like My 600-Pound Life, because we can store energy infinitely until we die, of course. And so we also know that in our brain, in this area called your hypothalamus, in a smaller area of your hypothalamus called the arcuate nucleus,
Mhm.
there is an appetite center, and that appetite center regulates your energy, your weight, basically your appetite.
Mhm.
And
Sure.
there are mechanisms that your body protects, because that is a primitive mechanism, just like your pH balance, just like your temperature. Energy storage is a primitive mechanism that your body has to maintain because it is a survival thing, right? And in fact, I would argue that your energy storage is the most important primitive mechanism in your body, because you can't do anything else without energy. You can't breathe without calories. Your heart can't beat. None of the other mechanisms of your body can't perform unless your body has enough energy, calories to perform those tasks. And so your body protects what it believes is the stored calories that it needs.
Mhm.
And it regulates it very, very tightly. And so when you deviate from that, your body has mechanisms in which it protects it or tries to get you back to your set point weight. And some of those mechanisms are in your gut, and some of those mechanisms are related to hormones in your gut, the so-called gut hormones. And so we have gut hormones, and then if that doesn't work, your body has something else it can regulate called your metabolism. And we can do things to regulate your metabolism. So your body has a number of ways that it can protect its set point. And one of the questions that will come up, I'm sure, in this conversation is, well, my set point in college is different than my set point now. And that is true. People's set point change and their weight goes up over time. And so the first question that was asked to me was, maybe explain what the definition of obesity is. And in America, the definition of obesity, there are multiple definitions of obesity. However, on a global spectrum, if you will, the easiest measure for measuring someone's weight is to use something called a BMI. And the reason that that's the easiest is because it just takes your height and weight. So you don't, there's a small room for error if you take somebody's height and weight and you divide it and you get a BMI. And so, but there's a lot of controversy over BMIs because the BMI doesn't apply to everybody as far as if they do have obesity or if they have unhealthy weight. A good example, a quick example, is a football player, right? That's all muscle. Their BMI would be high, but it wouldn't be mostly fat. It would be mostly muscle. At least maybe the offensive line, that might not be the case. But anyway, that's a different story. But the point is that it depends on what that weight is composed of. Is it mostly muscle? Is it mostly fat? And so there are other ways to tell that. You can do a waist circumference. You can do a waist to hip ratio. You can do what we do in our clinics, which is a DEXA scan, which we know from internal medicine and primary care. That's called the bone density that we use for osteoporosis. But you also use that test, which is the gold standard, to tell somebody's body composition. And the other machine that we have in our office is called a BIA, which is a bioelectrical impedance analyzer, which you stand on. It's like a scale that you stand on and measures your weight, but it sends an electrical impulse through your body, and then it can calculate your weight in pounds and your fat in pounds, and we can tell your body composition. And that is the true way to tell if somebody has obesity or not. The BMI is the quick and dirty screening test. But then if there is any question as a physician or the medical provider in general, you should look a little deeper, so that if their BMI is above 30, which is the definition of obesity, 30. So the definition of weight in general is that any BMI less than 25 is considered normal. A BMI between 25 and 30 is considered overweight. And any BMI above 30 is considered obesity. And then you can go to morbid obesity or severe obesity if you get above 40. And then sometimes we call it morbid or severe obesity depending on if you have other medical problems associated with it. But anyway, the numbers are 25 or higher is overweight, 30 or higher is obesity. And then, so if you use those numbers, 42+% of adults in this country currently have obesity. If you add overweight to that, anybody with a BMI above 25, we are upwards of almost 80% of all adults. I don't know any other disease, because obesity is a disease, that 80% of adults are inflicted with. Even if you just say, well, no, leave overweight out of it. Okay, I don't know any disease that 42+% of adults have. And by 2030, which is how many years from now? About 5, a little less than 5, it will be 50% of adults will have obesity.
Mhm.
And so, and if you add overweight to that, the number overweight, how many people will be overweight and obesity and have obesity will be 90% of all adults will have overweight or obesity. I don't know any disease that 90% of us have. So this is an epidemic. And this is an epidemic not for aesthetic reasons, looking, I just want to look at this is a medical condition that leads to other medical conditions that we know, like diabetes, high blood pressure, cancers, particularly certain cancers we could talk about. So it is something that we need to address. And the good thing is now we know how your body protects your set point and why it is difficult more so to maintain weight loss than it even is to lose weight. So people can lose weight, but 90% of us regain the weight that we have lost. This has been proven. And so why is that? Is it that 90% of us are sloths or gluttons? We just don't care? Or is it something deeper than that? And it is something deeper because the science proves it, and we can talk about it. And the good thing about that, though, is that your body will do whatever it can, whenever it can, to take advantage of hunger and cravings. And if I can control your hunger and cravings, which are emotions, I can control your weight. And your body knows this, and your body can control your hunger and cravings with these gut hormones that we all have. And because we know how your body does it, the pharmaceutical companies have taken advantage of that and have identified most of, if not all of them, and have made them commercially available. And there are more to come that we can use as medications to help control people's hunger and cravings, and also insulin resistance, which is a big part of obesity.
Yeah,
I said a mouthful. I'm sorry, but we could break it.
No, that's all right, man. The thing of it is that you put it in a light that we don't usually think of, as you know what I mean. You come in a direction that I think we need to know about now because of what's available for our patients out there. Number one.
What are these gut hormones? And
Hold
what do they
on,
do?
hold on. Dr. Lee has had his hand up for some time, so I want to go to Dr. Lee first. And go ahead, James.
Great. Thank you, Dr. Hunt. That was wonderful. We all see this in practice. Patients on GLP-1s, and I think your talk certainly targets this population, and you kind of alluded to it. I'm not sure if the GLP-1 was something you instituted a while ago when you referenced the 10 to 15 years ago. You were already ahead of it. But what I'd like to know are what are the risks and benefits of this medication, and are they long-term solutions?
Good question. So for the listening audience who may not know what a GLP-1 is, GLP-1s are the medications under the brand names like Ozempic, Mounjaro, Wegovy, Zepbound, Saxenda. All of these medications are called GLP-1 medications, and they are gut hormones. So that's kind of what Dr. Court was alluding to too. So these hormones are the gut hormones. So when my patients come in, the first thing I talk to them about are these gut hormones. We talk about the set point and we talk about these gut hormones. And there's only one hunger hormone that we know of, and that hormone is called ghrelin. Ghrelin is your hunger hormone. In my book, I call it the hunger gremlin. It makes you want to eat. It gives you that food noise. There are roughly about 7 satiating hormones that make you feel full, hormones that make you feel satisfied. And the way your body controls hunger and cravings is by adjusting these hormones, so that if you lose weight, your body will graze ghrelin, that hunger gremlin, and decrease your satiating hormones. One of those satiating 7 that I talked about is called the GLP-1. Another one is called GIP. So the latest of the medications out there have 2 of them in it. It has a GLP-1 and has GIP in it. The next one coming out next year is going to actually have 3 of the 7. The next one's going to have 4, so on and so forth. GLP-1 is a naturally occurring hormone in your body. It is produced by your intestines. These cells called the L cells in your hind gut and right before you get to your colon. And and the way your body uses GLP-1 is that when you eat food, you have to get full. And your body goes and the food goes down and gets to the hind gut right before it gets to the colon. And once that food reaches there, that's called the ileal brake. Your body secretes GLP-1 and say, hey, buddy, stop eating. We're good. It's enough food down here. And that's how your body regulates your being full. And so what that GLP-1 does is, one, that signal goes to your brain that you no longer have the craving. It competes with ghrelin. And you're not hungry. You feel satisfied. But also, it slows your stomach down so that you get full. And so you feel the physical nature of fullness, but you also, in your brain, don't have the craving for the food. And so that is how a GLP-1 works. But that's not how we discovered GLP-1s. We discovered GLP-1s because they're involved in insulin physiology. And so we discovered GLP-1s because of diabetes. And the first utilization of GLP-1s was not for weight loss. It was for diabetes. And so when I told you I've been using these medicines for 10 or 15 years, I lied. I actually been using them for 20 years because initially I was using them for diabetes. So people don't realize that GLP-1s have been out for 20 years. We think they are new medicines. They're not new at all. They have become popularized more recently in the last 4 or 5 years because of weight loss and the celebrities that are using these medications for that. But this medicine, the first one, ezetimibe, which is Byetta, which is the brand name, was used, came out in 2004 for diabetes. And it has been used for diabetes up until 2012 when when we first started using these types of medicines for weight loss. And then it didn't get really popular until the once-a-week ones came out about 4 or 5 years ago. So I've been using them for, roughly 15 years for obesity, but I've been using them for diabetes for, 5 years before that. And so, yes, these medications are used for diabetes because they help you regulate regulate glucose from an insulin dependent manner, so that if you were to have a glucose load or you ate anything that had carbohydrate in it, it would help your body stimulate insulin to control that carbohydrate. Because what happens is that carbohydrate turns into glucose, as we know. Now, are these medications safe? The short answer is yes, because we have 20 years of data on them. They are one of them, the daily one, is 98% similar to what you generally make. The once a week one is 94% similar to what we normally make. And the reason it's only 94% because they had to change it a little bit to make it last a week. And so so these medications are safe. Can you use them lifelong? So now I put my weight loss hat on. So the way I answer that question, because patients ask me that question every day, well, doc, I don't want to be on this medicine forever. I just want to take it and get off of it. Okay. Well, the physiology of weight loss, of weight management, dictates that your body has a set point. And so your body will try to maintain a set point for a number of years. And so so what does your body do to regulate your weight? Let's say your weight is 250 pounds. If you lose weight, your body will try to get you back up to 250 pounds for years. And the way it does it is as I mentioned, that if your weight is now down to 200 and you lost 50 pounds, your body will raise ghrelin and keep ghrelin elevated. In fact, we've done rat studies where we infuse ghrelin into their brain and they eat until they vomit. And I talk about this in the book. Same rat, you stick a catheter in their brain and you block ghrelin, they will stare at the feed until they starve to death. And I obviously can't put a catheter in your brain, but if I were to put a catheter in your brain, you would respond the same way. See, we all think that we have free will, and we do have free will, but willpower and free will are different. You can have willpower, and then you have the free will to eat a Big Mac, let's say, or not. But what I would argue is this. I don't know any person in the world, not one single person, who has willpower 24 hours a day, 7 days a week, 365 days a year. But your body and its primitive mechanisms does. It will have ghrelin elevated. So the day you don't get a good night's sleep, the day you have an argument with your loved one, the day somebody at your job pisses you off, you don't have that same kind of control. Now, if we lived in a utopia and everything was perfect and we were kumbaya and everything was happy, then we probably wouldn't need to worry about willpower because we wouldn't need a willpower. Everything would be perfect. But your body takes advantage. And in fact, people who have sleep apnea have very high ghrelin levels because they don't get a good night's sleep. We know that because we've done studies on that. And so that ghrelin is your hunger gremlin. And so it gives you that food noise and it makes you crave. You kind of always want something. And then it decreases your satiating hormones, that GLP-1 hormone, that GIP hormone, that OXM, all those 7 hormones that I told you about. It decreases it so that you never quite feel satisfied and you kind of always want something. And it does that consistently. Your body doesn't get tired. It does it consistently. But when you get back to 250, it goes up. Because mind you, your body doesn't have a preference. In fact, if you went up to 270, the hormones would work in the reverse. It wants you back to whatever that says. It's like a thermostat, right? So if your thermostat is set at 80 degrees in your house and your temperature goes up, well, the AC is going to kick in and bring you back to 80. If it goes down, the furnace is going to kick in and bring you back to 80. That is the same simple mechanism that your body uses in the appetite center. If your weight goes down, ghrelin goes up, satiating hormones go down. When you get back to 250, they even out because your body wants you to eat. So, because there's no wonder, right? Why if I lose 50 pounds, I get down to 200, right? Why don't I just gain 10 pounds back? Or hell, why don't I just gain 25 pounds back? Why do I gain 50 pounds back and then stop within plus or minus 5? 90% of people, that's what happens. Some people are outliers, they gain way more, but 90% of the people who regain weight gain right back to where their set point weight is. That is not a coincidence. That is science. And in fact, I use that science to make myself look smart because my nurses come in and they go, Mr. Such and Such is back. He ain't been here in a year and a half. You want to know how much he gained? I go, whoa, give me a minute. I go on my Epic EMR system and I look at his weight when he first started. I'm like, he probably like 250, 249. And my nurses go, you know that. It wasn't, I just looked at his first weight because I know what his set point weight is and I know what his body was going to get him back to. That happens all the time.
Okay. Do you know, you're hitting some excellent. But we have some questions, and I'm going to let Dr. Patrick Anderson start his question. But before that, Dr. Garrison, you got your on mute. Introduce yourself real quick.
Hi, Jordan Garrison, I am a general vascular bariatric surgeon. My office presently is in Hackensack, New Jersey, and I'm listening to this young man talk, and we're listening.
Okay, Jordan. Okay.
Okay.
And the next is Dr. Ali. Dr. Ali, thank you for joining. Dr. Ali's from West Coast. Go ahead, brother.
Hi, good morning from the West Coast, from California.
Good
I'm
morning.
Dr. Mazhar Ali, gastroenterologist at Scripps Clinic in San Diego.
All right, sir. Patrick, go ahead. Ask your question, brother.
So, Romac, Dr. Hunt, if I was confused about weight loss and I look at this panel, I'm way more confused. I've got a gastroenterologist, I've got a bariatric surgeon, I've got an orthopedic surgeon that I adore. This brother advocates exercise, but not just any exercise, but good quality exercise. I have Dr. Cord, who beats upon these patients about just their weight in general and management of diabetes. And then here comes Dr. Bay. He's like my go-to nutrition coach. And I'm realizing that everyone's got a part to play. And I'm just curious how each of these specialties, with their individual intervention, influences these gut hormones that we talk about. Because it always seems like there are forces that they're opposing forces. Whatever Dr. Lee does, it influences the lowering or the raising of one of these hormones. Whatever Dr. Garrison does, when you remove part of the stomach, you ties off part of the stomach. How does that influence the production of these hormones and how they in turn influence insulin production? Because in the back of my head, from a gynecologic perspective, I'm always thinking the thyroid, insulin production, all these things influence hormones, other steroid hormone production, which in turn influence weight gain. And this weight gain is usually weight gain that's primarily adipose tissue or in fat tissue and not necessarily muscle.
That is an excellent question. I'm not, or a comment. I'm not even sure if you were asking a specific question.
I'm not even sure I asked a question.
That's what I'm saying. But I can comment on what you said. Or if there's Dr. Bay, if there's somebody else who had a hand up, I can't see. We can.
Yeah, Dr. Lee had his hand up as well. But Dr. Lee, do you want to ask a question or?
No, mine was answered. My GLP-1 question. I'm
Okay,
happy with that.
all right. Then go ahead, Dr. The thing of it is that, and I understand what Patrick is talking about, because weight is something that affects each and every one of us in our practices. And the understanding of weight, I think, just scientifically, we are learning more and more and more about it, because it's something that's always kind of been put on the back burner, because we felt that, I told them, I gave them a diet, but they didn't do it, and there's nothing I can do with that. I have several questions for you myself, and you hit on something that, and I trust Dr. Aluya was here because he always talks about epigenetics. And our DNA actually is the number one thing that lets us know what our body's going to do, how big we are, how large we're going to be, how fast we can run, whatever we can do. Our DNA is the reason that we can do that. You were talking about set points as far as weight is concerned. And my question is, can you change that set point? Because if someone comes in at 250 pounds and they're 5'3", I can't imagine that's their set point. That's the point that they walked into my office. But can you change that set point that, okay, now I came down to 120 pounds or 150 pounds, and that's going to be my new set point? How do we do that?
So that is the golden question, right? So that the truth of the matter is, if this set point theory is real, which it is, then the real goal is to just go in the person's brain, grab the thermostat, and say, hey, what would you like your weight? You want it at 120? Okay, perfect. Let me turn it down to 120. And your body would do the rest, right? We're not there yet. But we do know set points are real because we do studies. We do rat studies where we we give them a hypercaloric diet, and we see the hemosiderin in their brain that burns that area of the arcuate nucleus of the hypothalamus. And
Mhm.
so we do know that that the set point is a inflammatory process. And can you cool off that inflammation and reset the set point? So there are people in the around the country who, in the world for that matter, because there's a lot of research obviously everywhere, that are in the camp that you're doomed. You can't change the set point, which is why some people say you got to be on these. And I didn't really answer that question fully, that you need to be on GLP-1s for the rest of your life. This is why sometimes when people have bariatric surgery, they still regain weight, a lot of them, right? And so, and then there are those in the camp that, like me, who believe that no, I'm an optimistic, and I think I'm a cup half full guy. I'm like, no, you can reset your set point. But guess what? The answer, like most things, is probably somewhere in the middle, right? And so my theory, even though you can reset your set point guy, I do believe that once your set point changes, and it changes throughout the years because of insulin resistance. And someone mentioned insulin earlier, and how that changes, which is why in our population, the BMI, your weight, you gain a pound a year every single year. There's a reason. It's not that we supersize a pound every year. We did supersize back in the 80s. I have a good talk on that, where we look at the caloric intake throughout the country and the change and how it increased. But it's not like my plate was this size in 1980 and went this size in 2000. Okay, it did. But then it's not like 2010, the plate went this big, and then 2020 went this big, and then 2030 went this big, and then 2040 it's going to be this big. Like, that's not what's happening. It has gotten to the supersized point, but it's been that way for about 20 years, and that's what the data shows, right? But we still are gaining weight. So the whole calorie in, calorie out theory is not, that's called funny math, because the calories are the same over the last 15, 20 years. So then you say, I got the answer to that. The answer to that is that we're moving less. Well, Robert Wood Johnson Foundation did a study on that already. Every 50 state, they looked at the physical activity of every state in this country, and it's flat for the last 15. They did a 10-year study. They did from 2006 to 2016, and the study from 2016 to 2026 is coming out, but the data is going to be the same. That is flat. So it's not calories in, out, calories out, and that's a whole, again, another topic. But the long and short of it, it's insulin resistance. Fat cells build insulin resistance. It's a vicious negative cycle. So the more fat cells you develop, the more insulin resistance you develop. And the more insulin resistance you develop, the more fat cells you develop, and so on and so forth. And so the whole point about a set point is that you have this set point, and that if you decrease inflammation, if you lose the weight, if you decrease your fat cells, if you decrease your insulin resistance, that inflammation will get better. And so I believe, and I'm in this camp, I believe that you can reset a set point, but it takes 3 to 5 years minimum.
Yeah.
Minimum. Now, your body has a memory, so that if something major happens, traumatic, something big happens, your body has a memory, and it will remember that old set point, and you could go right back up to that set point. So that's why I say the answer really is somewhere in the middle.
Yeah. I got another question for you. Of course, you're so good at this, Dr. Court. Please,
Yes,
you
sir.
got your well. Hold
Yes,
on, hold on. I think Patrick had your hand up first, and then we'll go to Dr. Court. I'm sorry.
he can wait.
He can wait. Go ahead, Dr. Court. Go ahead.
I can't defer to Pop. You know, he deserves the chair. He always deserves the chair.
Okay, I'll accept that, sir. Okay, doctor. This probably dates me because I remember the days when we used to use Byetta. Why did it go out of favor?
The reason Byetta went out of favor, it's a GLP-1. That's the one
Yes.
that I mentioned, is
It's the same thing we're using now. Yes.
And it came out in 2004. It is a once daily. It is the first generation GLP-1, and so it went out of favor because they just made it newer and better. the delivery system. It came from a lizard's saliva. So they were able to manufacture the GLP-1s better than actually getting lizards and taking their saliva and extracting the GLP-1 from their saliva. They were able to purify it better, and so that these it can hit the receptor better, more efficiently, and have the affinity for the receptor better. Meaning that if I have an affinity for something, I can stimulate it better and longer and make it act more efficiently. Bietta was good. It was again the first generation, but they made it better. And it was daily. And also, again, the delivery system was like a harpoon plunger. And so now these newer ones are much better.
Mhm.
Following up on that, really, I have to get this in. Because we have a patient who was on Ozempic and she's having trouble. Is it possible that the receptor may have been damaged? Because now we cannot control her symptoms from diabetes with nausea, vomiting, and despite everything that we've done. So can they,
You can't
in
control
effect,
what
damage the
symptoms. You can't
receptor?
control what symptoms. You can't control nausea, vomiting, or you can't
Yes,
control her A1C. I'm not, which one?
A1C and yes, and nausea and vomiting.
So are you saying that at one point she did tolerate Ozempic and now she doesn't?
Yes, yes, she does not.
Um, that is not usually the case. If unless something else, there's another factor involved. In other words, if they've been on Ozempic for 6 months, a year, 2 years, they don't typically all of a sudden not tolerate it unless another factor is involved. So that is an unusual case, and I don't know if I would have to know more about that particular patient to know why she. I mean, because she had very. I mean, there's so many reasons it could be. It might not be the Ozempic. For instance, she still has diabetes, so she still has the she still can develop the sequelae, the issues that are related to diabetes. So thus, she can still develop gastroparesis, and that could be her reasoning. It could not be that it's the Ozempic causing. Like in other words, that might be a red herring that she's on Ozempic, and because she's on Ozempic, and because it causes nausea and vomiting, that must be the cause. That might not be the case. I would argue that it probably isn't the case. That it take a step back and say, she could have developed a gastroparesis because she does have, just like she can develop neuropathy. Like, so I think it might be deeper than just the Ozempic. Now, granted,
We've
the
explored
Ozempic,
that. We have had GI see her and whatnot, and we
mhm.
just don't have an answer to what is going on with this.
So the other way to figure it out is to stop it altogether and see if her nausea and vomiting gets better. And if it does,
It's been it's
then
been
that
stopped, but
means,
can
huh?
those substances cause hormone the receptor damage?
Not that we know of. You mean the GLP-1 receptor itself?
Yes.
Not that we know of. Not that we know of. But that doesn't mean we haven't seen that, put it that way. But that doesn't mean it can't happen.
But we don't have all the complications and side effects of those medications since they're relatively new.
Yeah, but that's what I'm saying. We think that they're relatively new, but you made the point yourself that
That we
Bietta
had
was the
Diet
first
was
one
there
that's
before.
20 years old. So we have to decide what we consider is do you have to be 50 years old to be relatively new or 100 years? These drugs are at least 20 years old and counting. So, and not only that, these drugs, by the way, are scrutinized more than almost any other drug. Obesity drugs are
Mhm.
scrutinized. I give a lecture on this too. Are scrutinized more so than, in fact, obesity one of the first class of drugs that had to do a CVOT trial, a cardiovascular outcomes trial, and they actually flipped it and then made money off of it. But what happened was the FDA said, because of fen-phen, if you guys remember that
Yeah.
drug, and all these other drugs, they said, ooh, these obesity drugs are just for cosmetics. So you have to prove now that they don't cause heart problems. And so they scrutinize every drug that I prescribe because of the historical issues. And so they make them do cardiovascular outcome trials before they approve them. And guess what the pharmaceutical company did? They did those trials and then got it approved for heart, because they realized that not only do they not cause cardiovascular issues, they actually benefit your heart. And so they were able to take those drugs and then make money off of it.
Yeah.
So they scrutinize the heck out of these drugs for every little thing. So if anybody were to find a problem with a medication, I would bet that it would be an obesity drug, because of the way that they have been scrutinized over the years.
Yeah. Yeah. Dr. Court, I know
Yeah.
that you're concerned, but and I remember there used to be a doctor that we used to send patients to that did, in-depth evaluations for the people with diabetes, and that may have the nerve, the nerve problems
Definitely.
secondary to the diabetes that's causing nauseousness and vomiting and stuff like that. But he's not around anymore, and I would definitely, this was a patient that we would refer to him so he could do his studies. Um, but I understand what you're saying. It's hard for me to really put together that the GLP-1 would be the primary cause of this lady's problem, um, as opposed to possibly the diabetes. But it is something that you should always keep in the back of your mind. It could be the problem. And in
But
medicine, I always say never say never.
her
You know.
sugar is controlled now, but she still is having a problem. And also, we had GI evaluate her. So I don't know if Dr. Ali has anything else to offer.
Did you hear the question, Dr. Ali?
Yeah, I did. And I was going to weigh in on this, and Dr. Hunt actually hit the nail on the head on a comment I was going to make. Sorry, I came in a little late, so I wasn't sure if this was addressed or not, but these GLP-1s, as revolutionary as they are, the way they work is by inducing or slowing down the digestive tract a little bit. It slows things down. You have early satiety. And as a result of that, nausea, vomiting are very common side effects. Actually, as they become more popular, my clinic visits and who I see in the office are a lot of referrals from patients who are on these medications. The other one that we commonly see is constipation. In this particular patient, Dr. Court, it's tough because, you have here, the thing that's hard is it's never black and white. And, and in medicine, that's always our tricky part. There's so much gray area. What could be a potential with this patient is perhaps these medications may have triggered some levels of nausea, vomiting. You may have done a workup for gastroparesis. So just to explain what gastroparesis is for folks, this is one of these complications that can develop from diabetes, just like neuropathies can, or eye problems. It's something that can happen later on in the course of diabetes. And sometimes the risk factors for developing this are independent of sugar levels, which means you could have really good blood glucose levels and you could be on top of monitoring everything, but you could still develop this gastroparesis. And what happens is the enteric nervous system, the nervous system that lines the stomach and the intestinal wall, just slows down its contraction. This is a rhythmic contraction that's occurring because of your nervous system is doing that, not you. You have no control over this. When it slows, it can cause slow emptying, nausea, vomiting. But on top of that, right, the way you diagnose it is with something called a gastric emptying study, where somebody
We
eats
did that.
something and they
We did
label
that.
it. Yeah. Now,
We
these
did the
studies, though,
emptying
are
study.
never 100%. Now, what we also notice is that people who have underlying functional GI disorders, meaning that sometimes we could do imaging, sometimes we could do endoscopy, we can do emptying studies, and it shows it's all normal. But the bowel motility completely alters based on so many level factors involved, and it's transient. There's some periods of time where people could be very symptomatic because that bowel motility is decreased, and then over time it can pick back up. It's an ebb and flow. So sometimes diagnostics on these can be very challenging. What we call that, though, is we call it underlying functional GI disorders. What's in that realm are things like irritable bowel syndrome, or another term that we use in the medical world is called functional dyspepsia, meaning that there's not an anatomic problem. I'm not finding it with that black and white diagnostic test that I have, but we know that there's something functionally wrong with the system.
Mhm.
So
Excellent.
continue your program, doctor.
Excellent. Excellent.
Sorry, I spoke too much there, but
Dr. Patrick Anderson.
Yeah, so like everything else, and Dr. Hunt mentioned it before: move more, consume less, decrease caloric intake. But that's the focus on your macronutrients, right? How does slowing the gut up, slowing the GI tract, influence the absorption of your micronutrients and hence improving the efficiency of your cellular function? What modifications do you make in your recommendations of patients when when you put them on these medications?
So, so it depends on what my target is. If my target is weight loss, I first focus on the macronutrients to address the weight loss. The micronutrients, we want them to consume, and we want them to have good gut health in their microbiome through fiber and things like that. But I keep it simple. I'm a firm believer of KISS, keep it simple, stupid. Like I start very simple, and we start with a low carbohydrate diet because we know the physiology of fat cell production. Fat cells are produced when you have high insulin levels and high insulin resistance. A good example is that if anybody is a pediatric person or ever did a pediatric rotation and saw a type 1 diabetic, type 1 diabetics, before they're diagnosed, they're skinny as a rail. And the reason is because they have no insulin, so they cannot, it's impossible, they cannot store fat. And so as soon as you give them insulin, because they require insulin, they start to gain some weight. That is the physiology of how you develop and produce a fat cell. The macronutrients, there are only 3. And so the reason I say calories aren't really calories is because what is the calorie made of? And what do you tell them to do with their calorie? The calories are 3 macronutrients. So if you tell somebody to decrease their calories, you just tell them to do this, like decrease their calories. That's what they do. Carbs, proteins, fat, they do this. That is not instructional. That doesn't tell me anything. It just says eat less, move more. And that's not instructional. For me, I need to tell them what to do with each of those 3 macronutrients. And I actually only start with 2 because I like to keep it simple. So I tell them to decrease their carbs. And why do I do that? Because carbs stimulate insulin the most. Protein doesn't really stimulate insulin at all, and fats don't stimulate insulin. I am primarily, not only, but primarily trying to burn fat cells. So I tell them to decrease their carbohydrates, which thus will decrease their insulin, because high insulin makes you store fat. In fact, high insulin prevents you from burning fat because there is an enzyme, this enzyme, for those who are not medical that are listening, these enzymes break down things. So there's an enzyme in your fat cell called HSL, which is hormone sensitive lipase. It is responsible for breaking down a triglyceride in order for that fat to get out of that fat cell. You cannot get out of a fat cell unless you break the fat cell, the triglyceride, down. And so you have to have the hormone sensitive lipase active in order to do that. And so if your insulin is high, it deactivates hormone sensitive lipase. You cannot burn fat if your insulin levels are high, period. And in fact, when your insulin levels are high, you store fat because there's another hormone outside of your fat cell called lipoprotein lipase, which is LPL. And that lipase breaks down the triglycerides so it can get into the fat cell. So that's how your body works. And so basically, insulin is a fat storage hormone. It is the only fat storage hormone that we know of. And so the goal to burn fat is to, from a simplistic perspective, it's a lot more complicated than that. But from a simplistic 1 + 1 = 2 perspective, you have to get insulin down. And the way you get it down from a macronutrient perspective is to decrease the thing that stimulates it, which is carbohydrates. You do not want to do just a generic low calorie approach, because yes, you get your carbs down. So yes, you lose weight. And I'm not sticking my middle fingers up at you guys, but you don't want to reduce protein. And the reason you don't want to reduce protein is because you want to maintain their muscle mass. And the reason you want to maintain their muscle mass is because you want to maintain their metabolism, among other things. And also, muscle helps to reduce insulin resistance. And so we need to approach it from not just a generic calorie approach, but you got to tell them what calories to eat, and then how much of it to eat. If we just say reduce, get a 1,500 calorie diet, that is not instructive, because I didn't tell you how much of that 1,500 calories should be carbs, how much should be protein, so on and so forth. And then the final thing I'm going to say about calories is this. We all are of the age where there used to be these, and they don't do it anymore because it's not politically correct, but they used to have these commercials called Feed the Children. And in those commercials, there were two types of kids. There were these really skinny kids that they were just emaciated. You could see their bones, their ribs, and they had flies over them. And they would sit there and they'd give us $20 in a month to feed these kids. Those kids from medical, if you remember back from the medical school, those kids are called marasmus kids. Those are kids who have a total calorie deficit. They're called marasmus kids. The other kids, and I remember when I was a little kid, I was like, they starving, but they had these big old pot bellies. Remember that? Remember that? And then they had these skinny old arms and legs. Those kids are called kwashiorkor kids. Kwashiorkor kids are also starving. However, they eat enough calories. They actually eat more calories. They eat like 2,000, 3,000 calories. So that's why calories in don't equal calories out. That's, again, a whole nother lecture. But those kids have enough calories, but they are poor. And so they're devoid of all protein. They are protein deficient. And that's what kwashiorkor means. And so these kids have big old bellies. And so this tells you, this is the reason I'm saying this, it's because this tells you the physiology of macronutrients. So these kids have big old bellies that are full of fat. It's also it's fluid in there too, you're right, but it's full of fat. And the reason it's full of fat is because these kids, their diet have enough calories, but it's 100%, 100% grains, 100% carbohydrate. And guess what 100% carbohydrate does? It drives up your insulin levels. And when your insulin levels are that high, you store fat and you cannot burn fat. It is stuck in your belly. And guess what your body has to do in order to get the energy it needs and to breathe, to make your heart beat, to make your brain function? It has to get those calories from somewhere, and it catabolizes your muscle. And that's why these kids have skinny arms and legs. They have no muscle mass, and they die eventually once they catabolize the muscle.
All right. That is so true. Hold on, I see hands going up, but what we need to do is we need to take our halftime break. And marasmus and kwashiorkor, boy, oh boy, you're giving a medical school lesson here. I love that.
Yes, he is.
Let's do this. Let me do my halftime spiel here, and then we'll introduce the physicians again. Then we'll get to some of these hands. And I'm just so proud of what we're doing here today, because this is the awesome lecture. I do have a couple of questions for you myself as well, because you hit on a couple things that I just think are key. Let's see here. Okay, so what I'd like to do is first, let's reintroduce all the doctors. Dr. Court, can you start off for us?
That's James Court, internal medicine. I practice in East Orange, New Jersey. I only treat adults.
All righty. Dr. Garrison, I know you're driving, but can you reintroduce yourself, please? And Dr.
Sure.
Garrison, you got to understand, you know where he's going today. He's going to WBGO. He's going to be a DJ. Are you on the radio today, Jeff? Dr. Lord?
No, not on the radio. I'm just shaking some flesh. But my name is Jordan Garrison. I am, for the purpose of this lecture, a bariatric surgeon. I've done bariatric surgery for 20 plus years, and I got a ton of questions. Okay, and so I'll be patient and wait my turn. Omar. You know, Dr. Bay set me up for this because he always wants me to come on and be a little controversial, take a different position in it. So, you know, if I do, it's Dr. Bay's fault. Okay. Okay.
I work with a lot of bariatric surgeons, and in fact, my practice is a comprehensive. So I already know what some of your questions are going to be because I work intimately with bariatric surgeons. So I welcome the conversation because I think it'll be very, very healthy and informative.
All right.
All righty. Dr. Lee, please.
Yes, Dr. James Lee Jr., board certified orthopedic surgeon. The name of my practice is called Modern Orthopedics in Paramus and Parsippany, New Jersey.
All right, thank you. And Dr. Hunt, you can introduce yourself as well.
My name is Dr. Ramik Hunt. I'm a board certified internal medicine physician and board certified obesity medicine specialist, and I run medical director of comprehensive obesity medicine practice in Princeton, New Jersey.
All right. And Dr. Hunt, before we leave, please, you got to give for the audience your phone number, your office number. I've had several Facebook people ask for your number and where and how to contact you. Okay.
Yes.
Dr. Patrick Anderson, please.
Yes, Patrick Anderson, board certified gynecologic oncologist. I practice in South Orange and in Newark, Beth Israel, under the auspices of the Barnabas Health Medical Group.
Okay, thank you. And Dr. Ali.
Hi, Dr. Mazhar Ali, gastroenterologist at Scripps Clinic in San Diego.
Mm-hmm. Dr. Aluya, please.
Yes, good afternoon. Sorry I came in late. Nelson Aluya, medicine pediatrics, currently interim chief medical officer for St. James Health and medical director for Alliance Rehab. But my primary interest is on, adult medicine, especially with diabetes. Pleasure to be here.
All right, thank you, thank you. Understand that our webinar is every second Saturday of the month at 1 o'clock. Okay, and if you want to see our past webinars, please, you just go to obhealthy.com and look at our YouTube logo. Just click that. All of the past webinars come up, or go to the doctors tab and you'll see a little camera there. Just click that and you'll see all our past webinars. Please subscribe to YouTube so we can continue to bring this to you. The most important thing that I can say today is please do not change any aspect of your medical care until you consult your physician, because only your doctor truly can take care of you from a medical standpoint. Okay, I'd like to thank OBHealthy for allowing us to bring this webinar to you, and we are going to get go. Oh, by the way, I'm Dr. Omar Bey. I'm a retired pulmonary critical care physician, and now I'm director of nutritional support for the intensive care unit at Beth Israel Medical Center. And thank you very much. All right, I always forget to introduce myself, so there it is. All righty, I think what we're going to do at this particular point is, Dr. Court, you have another question, and then hold on, Dr. Court. Let me do Dr. Garrison because he's running to a meeting at WBGO. Dr. Garrison, can you hear me? Dr. Garrison,
Yes,
can you
sir.
hear me? You have your hand up.
Me?
Go ahead. We're going to
Yes,
make you
hold
next
on.
as far as the question.
Who, me?
Yes, you.
Garrison. Okay.
Yes.
Listen, how much time do I have? Okay. First I kind of want to focus in on what Dr. Anderson, when he said, I don't know if I asked the question or not, but I think what he was getting at is that what I've learned is that there's, like they said, there's more than one road that leads to Rome. With this obesity thing, there's about 100 different paths.
All righty. see if we can get him back here. All righty. I think because he's driving, he's probably out of an area that we can hear him. So hopefully he'll come back and we can finish that off. Okay. Dr. Court, go ahead with your question.
Be quick for Dr. Hunt because I see so many patients who are pre-diabetic. What is a simple formula that I can tell them? Reduce
for pre-diabetes or for
so that it doesn't progress to full-blown diabetes.
yes.
Reduce your carbs and increase protein.
But
can I just finish here, guys?
Oh yeah. Go ahead, Dr. Garrison. We lost you there for a minute. Go ahead.
Oh, okay. So I'm just trying to give some context to this. First of all, the human being on this planet is an intraspecies, and there are changes. And the changes, when we're talking about set points, the basic physiology is that we have been taught, our bodies, our DNA has been taught that we're starving, and that our body is going to do everything possible to maintain that weight. And even more so, not just to maintain weight, so that that we'll have enough. That's our DNA in us. We got rid of it yet.
We're not hearing you.
We're not hearing you, Dr.
Breaking
Gordon.
up.
We're not hearing you. You're breaking up.
Dr. Garrison, we're not hearing you. All
Okay,
right.
let me.
If you get to an area where you're stationary, let us know. But we're not hearing you. You're in and out.
Well, I'm going to do that.
We can hear you right this second,
okay,
though.
this is. Okay, well, I'll just sit here then. So what I was saying is that we just haven't gotten past the point where our body physiology and DNA has been able to change the set point. And and Dr. Hunt, 99% of what you're saying, I totally agree. So you might, I don't know what kind of bariatric surgeons you're working with, but I agree with you, man. I agree with you. There was one thing, again, I'm coming from a patient perspective. When we talk about willingness, we do know there are diseases that there is willingness. So I don't want to give the impression to these patients or our listeners that there's nothing you can do, that you're fat, you're going to be fat, you're going to be overweight, and there's nothing we can do. And these medicines are just temporizing. No, this disease of obesity is multifactorial, and we have not even addressed. I know we're talking the medical part of it, but what about the sociologic part about it? What about the psychological part about it? What can we do to address those things? When I give my lecture, there's one thing that I talk about. It's called your incredible shrinking day. And what our society has done as far as the time to work, the amount of work we do, the requirements that we have in raising our children, doing homework, and things that our parents did not necessarily do, we spend enormous amount of time doing. We watch every pitch and every jump shot at a kid's soccer and basketball game. We take them everywhere. We used to have to ride our bikes everywhere or walk. Right? So we've eliminated that from our kids. And now they have these motorized bicycles. They don't even pedal anymore. So we have changed our society. And as you're talking about, the drug companies have taken advantage of it. So have the supermarkets. The supermarkets put the things, as you're talking about, carbohydrates versus protein, high carbohydrate, high good tasting foods, easily accessible. And if we don't have time, so what we do, we grab Marie Callender's lasagna as opposed to going to get some fresh fruits and vegetables because it's quick, it's easy. Our time, we have very little time to do things such as exercise. We have very little time to do things that are healthy for our body. So this is a multifactorial. I don't want to give the image that there's nothing you can do. These drugs are the be all and e all and answer to it. And there are other things. Now, if we want to get into surgery, there are certain, yes, surgeries decrease transit time, decrease the amount you can eat, but also there are surgery like the duodenal switch, and I want to get into that, in which we do try to eliminate that your gremlin response. So there are a lot of things, and I'd like to, hear some comments and some discussions, not just on the physiology and the medicine that we learned, but what can we do to help patients? I'm sure when they come into your office, the first thing you say, okay, I'm going to put you on Ozempic. I'm sure you counsel them on all the other things that they can do, should do to help. All these things we do are adjuncts. Surgery is definitely not a cure-all, but we know it is a tool. And if used properly in conjunction with diet, exercise, and I'm going to close with this. After my seminars, I take some of the patients who have had surgery out, and we talk. And within 5 minutes of our conversation, it all goes back to what they eat. It all goes back to food and consumption. So that to me is a psychological thing that has to be worked on. And so, we don't have a psychologist here, but Dr. Bay, you and Dr. Court, you guys counsel your patients on these things. So I'd like to hear a little more about that. So, Dr. Hunt, you sound wonderful. You're doing a great job, and we appreciate you, man. Thank you.
you.
Excellent, excellent.
Um,
Yeah, go ahead, Ramit, go ahead.
So I think that's Dr. Garrison, thank you, and that's a great points that you made. And to get into what you said. So when I started my program, I was the nutritionist, I was the the therapist, I was the personal trainer. It was just me, and then I grew it out. But but the 4 pillars. Again, let's go back. I try to keep it simple with the patients and move forward. But there are 4 pillars of weight management. One is nutrition. In fact, nutrition, as Dr. Garrison said, is 80 to 90% of weight loss. A study just came out about that reaffirmed that. Physical activity is 20%. We want that 20% because it's good for your heart, it's good for your brain, but it also is probably more than 20%, right? Because when you're doing a physical activity routinely, it makes you disciplined on that 80%, that 90% of nutrition. So anyway, the first thing is nutrition. The second is physical activity. These are the 4 pillars. The third is behavior modification, what Dr. Garrison talked about as well. And then the fourth is medications and or surgery. And so we address it from all of those perspectives, right? And so because nutrition is 80%, that's what I start with. In fact, I don't even talk about physical activity until the 2 or 3 visits down the line. And also it's a strategy, right? If you took me and said, here, throw this 30-pound vest on and then run up a hill, I'm gonna sprain something, right? I'd rather get 30 pounds off of you and gradually get your physical activity up, because if you get hurt while we're doing my program, you might just get discouraged. And so we specifically tell people what to do as far as a nutritional plan, but I'll give you guys a general because it goes with that. What Dr. I think Court asked this question. I can't remember who asked me the question, but about prediabetes, we need to give people specific targets, just like we give them specific targets for calories. And so we know that carbohydrates do not have any nutritional value except for glucose. They give you energy, but you can get glucose and you can get energy from other sources, ketones. There's something called gluconeogenesis. There's something called glucagon. There's a lot of ways to get glucose. It doesn't have micronutrients, as mentioned before. Carbohydrates are nutrient void. They're void of nutrients. In fact, you have to fortify carbohydrates in order to give them nutrients. So you fortify it with vitamin D. You fortify it with whatever you want to fortify it with. A carbohydrate doesn't have nutrients, except for fiber. Fiber is a prebiotic or pre this, and so we can talk about that. But carbohydrates in general do not pack any nutrients. What they do though, is that they increase your insulin levels. And so in order to get your insulin levels down and to help glucose management, especially in someone who has insulin resistance, you should get your carbohydrate levels down to less than 150 grams per day. If you want to lose weight, you need to get your carbohydrates down less than 100 grams per day. Now, the typical American diet, just a regular diet sitting here now in a day, is 300 to 400 grams of carbohydrates a day. Massively more than what we should be eating, which is why we have insulin resistance in this country. Note, type 2 diabetes used to be called adult onset diabetes. The reason we no longer call it that, and that's because literally only adults got type 2 diabetes because it was related to obesity, basic or insulin resistance, I should say, more specifically. As of when I wrote my book, A No Guesswork Diet, as of 2020, when I released my book, it was over 100,000 kids who had type 2 diabetes. We no longer can call adult onset diabetes, which is why we changed the name to type 2 diabetes officially. You can know because it's no longer adult onset because kids get it. And the reason they get it is because of insulin resistance, because we have too many carbohydrates in our diet. So you have to give them targets. And so 150 of carbohydrates and 100 if you want to lose weight. Now, I have my own Dr. Hunt theory, whereas we are all individuals. So that, yes, 90% of the population needs to be below 100 grams of carbohydrates in order to lose weight from a low carbohydrate perspective. But everybody's individual. For instance, my number, and that's what I say, what's your carb number? My carb number is 70. So I personally have to be below 70 grams of carbs per day in order to be in weight loss mode. You might be 90, Dr. Bay, you might be 70 like me, or you might be 50, which is ketogenic, which is fine, by the way. But everybody is a little different. But most of us, 90% of us, need to be below 100 to lose weight. Now, for weight maintenance, it's a different story. Weight maintenance, you don't have to be that low because you're not trying to lose weight. You are maintaining your weight. You have to be somewhere below 150. And so that is how I approach the carbohydrates. Protein, this is pretty clear. Mayo Clinic has specific guidelines. Protein requirements are a lot higher than we used to tell people to have it. When you are actively losing weight or when you are actively working out daily, it is 1.2 to 1.7 kilograms per grams per kilogram for people, which turns out to be roughly about 100 grams of protein per day for people who are trying to lose weight or people who are actively in a vigorous physical activity, trying to gain muscle, that kind of thing. And so we tell them, the goal is to track your food and let us know what you're eating. And we do not try to change their diet. We try to modify their diet. Because if that's the case, I could just give them a meal plan and say, here, eat this. Here's a bunch of cardboard. Eat this every day. You'll lose weight. Yeah, they'll lose weight if they eat cardboard, but it's not sustainable. Right. In my book, I talk about the 6 S's: simple, sustainable. So we have to keep it simple. And so we try to modify their diet, what they're eating and their lifestyle. Some people are on a go. My biggest loser who lost 230 pounds, we talked about not eating so fast, like little things like that. Right. So for for breakfast and for lunch, he was on a go. He's a busy lawyer. But we talked about how it takes your brain 20 minutes to get that signal that your stomach is stretched, right? So for dinner, he would eat his meal in courses. And that is how he slowed down his dinner. So he would eat his salad first, drink his water, get up, put it in the sink. He liked soup. He'd eat his soup, get up, put it in the sink. And then his main meal was half the size, but he felt just as satisfied because that process took 20 minutes. And so things like that, we personalize. It's not a one-size-fit-all thing.
Yeah, you're right.
If I might ask a question, I tell you, I love what Dr. Hunt is trying to say. But the more you talk, brother, the more you confuse me. Okay, because it's such a complex subject matter, right? You talk about weight loss, but then you kind of dabble into weight maintenance, right? And I remember when I was in college playing soccer, running cross country, I used to say, listen, I work out hard so I can eat what I want. And here you are telling me I got to get rid of plantains and rice and bread. You know, you talk to your average person of color, they love bread, okay? But then you talk about weight maintenance. You know, my older daughter, who's a beast, she works out incessantly. When she was in college, she combat the freshman 15 by eating her dinner on a breakfast plate. You know, so it's identifying your need and implementing that parameter that creates that balance, right? How do you maintain versus lose weight? Because I am sorry, Dr. Hunt. I'd rather you give me a GLP-1 and tell me to get rid of a piece of fried plantain. It's just not going to happen.
No.
Educate.
I'm not sure if I'm being very clear. Let's stop here. And let me be very, very clear. Again, we modify, we don't change your diet, right?
Right.
So I don't want to get rid of your plantain. So now mind you, right? When a patient come into me, I go, newsflash, you ain't the only one that eat carbs. Because they'll come to me like, Doc, I'm Italian. You can't get rid of my pasta. Doc,
right.
I'm Puerto Rican. You can't get rid of my rice. Doc, I'm Jamaican. You can't get. I'm like, bruh, sis, I'm not trying to get rid of none of that. I am just trying to modify, right? And so, because I'm trying to modify, during the weight loss phase, you just have to modify that number. It doesn't mean you can't eat a plantain. It just means that I'm giving you $100 a day to spend in this weight loss phase.
Right.
Spend it how you want. If you want to spend $50 on a bag of chips, be my guest. You only got $50 left. If we go to breakfast and I eat eggs and I eat sausage, that costs me $1. That's 1 gram of carb. If we go to breakfast, you sit right next to me. I spent $1 on my breakfast, egg. I feel full, got my eggs and my sausage. If you had a bagel, that cost you $75, which means you got $25 left for your day. I got $99 left for my day. Spend your money how you want. Just don't overdraft. Don't overdraft. You only get
Right. Can you quickly comment on the timing of your meals and the concept of intermittent fasting?
That's important, right? So we could talk, there's so many things, right? And it's like, well, you didn't talk about that. I'm like, I didn't. I could. Hey, we got time. We can talk about it all. But that is so what I tell patients is not that you're going to do that, but if you had a Big Mac meal at 12 noon today, a number one Big Mac meal with a medium Coke, it will raise your insulin levels a certain amount. But the diurnal effect of hormones is a diurnal effect, meaning that if you have that same Big Mac meal, exact same caloric, at 12 midnight, it would double the level of your insulin. We've done this study. So we know that people have said this. If you eat late at night, especially carbohydrates, you will gain more weight because of the hormones and physiology of the diurnal effect of hormones.
Now, let me ask a few questions because I've been holding them, and when we were talking,
before you go there, real quick, the impact of sleep. As you talk about diurnal hormones, the impact of sleep on weight management.
That's a big one. I mentioned it a little bit. It's a lot of things. Testosterone is made at night, but ghrelin is also increased in people who have sleep apnea. So people who do not get a good night's sleep and have interrupted and broken sleep throughout the night have extremely high levels of ghrelin. People we have this night shift disorder. So people who work the night shift also have increased levels of ghrelin and other markers that indicate that people will gain weight.
Interesting. What about, you were talking about slowing up the transit time as far as the GLP-1s. do you find in your research, and is there any research on this, that micronutrients are decreased, like your thiamine and your selenium, your zinc? Is that a problem? I know when I used to take care of gastric bypass patients, so many of my patients had micronutrient, deficiencies. Do you find that with the GLP-1s?
So I do not find that with the GLP-1s because the brush border of the intestines is not impacted. With the gastric bypass surgeries. That is what we call like a replumbing, right? So you're moving things and you're skipping over the duodenum, and so you are where these micronutrients get absorbed, you are bypassing them. Why we call it a gastric bypass. The duodenal switch is another good example as where you bypass the areas in which these micronutrients are absorbed. And so when you bypass them, you can absorb them and they go right out, which is why we check them. And Dr. Ali, I think that I hope I pronounce your name properly, could attest to that, I think. And also Dr. Garrison might not be on here anymore, but could attest to because of you're bypassing key areas of the small intestines that are responsible for absorbing these micronutrients.
Dr. Ali, you want to expand on that at all?
Yeah, I agree. You're not altering the anatomy here, right? So your anatomy is intact. Your nutrients absorb in different parts of your bowel, right? Iron absorbs in your small intestines, in your duodenum, your jejunum. You've got vitamin B12 that absorbs in the end part of your small intestines. It doesn't absorb just necessarily everywhere. So when you take out these parts, then you're going to start developing these deficiencies. We don't necessarily need to check these nutrient levels in patients routinely, as opposed to patients who have bariatric surgeries, whom I see years down the road, and we still are working through their iron deficiency, or people who may have a surgery to remove a part of their intestines because of a Crohn's disease or a cancer or something, and we have to look at that B12 and measure it. We're not necessarily needing that for the GLP-1 medications.
Another question I had, we were talking about as far as losing weight and maintaining weight and weight maintenance. What about metabolic rate? We all have our individual metabolic rate, and I think our epigenetics sets that metabolic rate. Okay, and so do you get into that at all as far as the metabolic rate is concerned, as far as us burning calories? Putting that into the equation?
So I'm a numbers guy. I don't do anything without at least having the numbers to help me interpret things. I am the only comprehensive, and I don't like to tout myself, but that has the only comprehensive weight management clinic in the Northeast. Meaning I have everything that we are supposed to have. And some other clinic might have one thing and then but they don't have the other thing. And so one of the things that I have is something called a metabolic cart. And back in the day, we used to do, and you know it, we used to do metabolic carts in the ICU for people who were on tube feeds, right? So you can tell how much food requirement. So what a metabolic cart is, it basically it's called the indirect calorimeter or a calorimetry. And for those who don't know what it is, if you're old enough, there used to be this thing called the $6 Million Man, Steve Austin, and he used to have this thing on, and it was a pulmonary exercise stress test where he'd run on it and make him bigger and stronger. That is a pulmonary exercise stress test. That machine is the exact same machine that I have and use to do, that's exercise, your VO2 max, that what Steve Austin was doing. I don't want your VO2 max. I want your resting metabolism, which is called your REE, which is your resting energy expenditure, right? And so that is what I use on every single patient that comes into my office. I measure, you know why? Because people say to me, hey, doc, I'm not losing weight. My metabolism is slow. Well, how do you know that? Did anybody ever check it? The answer is no, 100% of the time. Why is it no 100%? Because nobody has the machine. So nobody checks metabolism. I check
Mhm.
metabolism on every single patient that comes into my office, every single one. And guess what I can tell you? That every metabolism is different. Whatever your MyFitnessPal tells you, or whatever Lose It, or whatever app you use to tell you how many calories you should be burning, it's wrong. And in fact, I do a lecture on this and talk to you. That's why I keep telling you calories are funny math, because there's so many holes I can poke into why a calorie is not a calorie. Because if you want to do calories, then you better give me the right numbers, because you don't even know what my metabolism is because you didn't check it.
Mm-hmm. True, true. I'm glad you hit that. That was so important. The other thing is,
Yeah,
and,
I
and
feel
Patrick,
like we
I'll
need
get
to
you.
do.
Go ahead.
Yeah, I
Go
was
ahead.
going to say, I feel like we need to do part two, because when Dr. Aluya is silent, I can tell you this is so much interest, because he
That's right.
usually come up
He's
with
listening instead of.
things that drive this conversation.
I love it.
But for Dr. Lee and myself, who do a lot of surgery, besides the preoperative implications of some of these GLP-1s, where they have to be off of it for a while before we can operate on them because of obvious, the gastroparesis element of it. Do you recommend modification of the use of some of these medications, or even modify your weight loss program? Because we're operating on a lot of people who they're obese and we're operating on them. But do you modify your program if they're on it during the recovery phase of a major operation, just so we can enable, adequate absorptions of micronutrients that will help wound healing and so on?
No, the reason, I mean, I modify, if anything, to one, I'm not in a rush. This is not an emergency in a matter of weeks kind of thing. So that if there is something specific that a surgeon needs, then they should follow the surgeon. They should take a break. You know what I mean? But if they don't have any specific instructions from the surgeon, what we tell them is to maintain, if anything, increase their protein requirement for healing, right? And those kinds of things. Because I keep it very simple. It is decrease your carbohydrates, which you should be doing no matter what surgery or what you're doing in life, and increase your protein, healthy proteins. And just of note, I start with a low carb, high protein diet. I don't care how you do it. Who cares? You can start with bacon. I don't care. I want you to get off of carbohydrates, because the question is always this: well, that ain't good. Compared to what, patient? Don't ever tell me what ain't good until you tell me what you comparing it to, because bacon is better than French fries or whatever. So let's get you off the carbohydrates, and then let's transition you to a low carb Mediterranean diet. Why? Because the Mediterranean diet has a lot of healthy fats, and it helps to drive down your LDL, which is your bad cholesterol. It is a heart healthy diet, even though people don't like to use the PreDimed data anymore, which was the biggest diet study several years ago. It demonstrated, but that wasn't the only one that demonstrated, that a Mediterranean diet is the best heart health diet. And so we do a low carb Mediterranean diet. We do not start with that. I am not a nutritionist. I do not like the way my nutritionist approaches patients. They read their book, they studied it, they know the answers. So when a patient comes in, they go, oh, I want you to do this. Then I want you to do that. Then I got to get your fiber down. Then you got to do this. And then you got to put your fiber. You tell people too many things in the beginning, you will get nothing.
Nothing, right?
So I don't do that. I do one at a time. I know what I'm gonna end with. If you stay with me, you on my train. I know where the destination is. I ain't got to tell you that there's gonna be a railroad crossing 2 miles, 30 miles. You don't need to know that right now. You just need to get off these carbohydrates, get your protein up, and we monitor your muscle mass, and we monitor your fat, and we monitor your metabolism, and we move. And let me do all of the math. You don't have to do the math. Let me do it.
All right. Patrick, just to expand on your question, back in the day, I did my training at the University of Penn, and Dr. Mullen back then was doing research. We were doing some research on protein sparing diets. That was back at the beginning. And what we did was we actually gave post-surgical patients, and a lot of these were obese patients, post-surgical patients, um, protein and very, very, very little carb or glucose or whatever you wanted to say. The protein was the primary thing that we gave these patients, and post-surgery they healed nicely with no increased infections, no, everything was good. So just to give you some research, we did that back in the late '80s. So that research came out with Dr. Mullen back in at the University of Penn. Um, One thing I would like to say is that, oh, one more question, Ramik, do you use fasting in any of your weight loss combinations? You know, a lot of people are like, oh, I fasted, you know, during the nighttime. Well, put it this way. I mean, there are some people I talk to and they like to fast, and or they asked a question about fasting, and I'm one of saying, well, guess what? If you don't eat breakfast until 9 in the morning, and you eat the last thing you eat at night is at 6 at night. Well, guess what? You fast. You know what I mean? You had how many hours of fasting because you didn't eat anything after 6 and you ate your breakfast at 9 and you felt satisfied all day and you don't feel like you're starving, you know what I mean, that you're restricting yourself. Guess what? You did fast. But do you have any aspects of fasting in what you do?
So that's a good question. So I don't initially recommend to the patients to fast, although they can.
Hmm.
Again, only because I want to keep it simple. But if that is what they what works for them, that's what we do. Listen, I'm fitting into your life. You're not fitting into my life.
Right.
So it is whatever works for you. But I can tell you this: Jason Fung, who he popularized intermittent fasting with this book, Obesity Code. But if you look at his book and you look at my book and you look at the section of his book and the section of my book as to why intermittent fasting works and why a low carbohydrate diet works, they look identical. Why?
Mhm.
Well, because the physiology is identical. So what does that mean? All back to insulin. If you reduce your carbohydrates, your insulin goes down, you burn fat. Jason Fung would say, well, what is a better way to reduce your insulin levels? Then what's a better way than reducing carbs to reduce your insulin levels? Don't eat at all. Then they go really low, right? That is the whole concept of, and if you look at his chapter, he talks about the reason, the way you do it and why it works is because you want to reduce your insulin levels. And my way is to reduce your carbs. It'll reduce your insulin levels this much, but if you don't eat at all, it'll reduce it that much. And so that is the whole point, and that is the whole concept of at least the bare bones of it. And so I have no problem with that. I encourage it if people want to do it, but we do have studies that show that it's not as sustainable long term. But if I know people who do it, and just like you said, Dr. Bay, people do it not unwittingly. They don't even realize that they're doing it, but they're fasting anyway. And the last thing I want to say about that is that these pygmy animals don't have fat on them, and so they have to eat every 60 to 90 minutes, otherwise they will die. And the reason is because if they don't eat and they don't have fat storage, they die. Humans actually have a lot of fat storage. And in fact, when we sleep every night, we don't eat throughout the night. Or I guess some people can or do or sleep, eat, whatever. But in general, we don't eat at night and we sleep, but we don't die. Why don't we die? Because we have fat storage and we burn fat at night and we produce ketones every single night. You produce ketones in order to survive. And in fact, I have a stepdaughter who you might sleep 8 hours. She sleeps 14 hours sometimes. And so she still survives because she has fat cells, right? And when you break fast or breakfast, I think, or break fast, however you want to call it, when you break fast, you pay your body back the fat that you burned. And your body gets that fat back. And then every night you repeat the process. These pygmy animals, you look it up, they call them hungry animals. They have to eat, not because they're hungry, but because they will not survive because they don't have the capacity to store fat. Humans have, so that way we can actually sleep for longer periods. without, in other words, we cannot eat for longer periods because we have reserve.
Mhm. Mhm. Excellent, excellent. All righty. You know, there's another question I wanted to ask, and and I'll get to you in a minute, Dr. Aluya. Um, Professional help. I mean, we haven't talked about that as far as someone who's really wants to lose weight, morbidly obese, or maybe not morbidly obese, but just don't have the willpower, just don't, or psychologically they need help. How do you handle that as far as mentally, giving them that support and professional help?
Um, by the time I'm at tertiary care centers, when people come to me, they've tried multiple places. So by the time they come to me, they already know that I'm going to send them to a therapist, and they're already ready for that.
Mhm.
But a lot of times people, 30% of people who have obesity have binge eating disorder. So a lot of times people have a lot of psychological baggage with them, right? And think about it. By the time they came to me, everybody, most people who are trying to lose weight, they have tried 7 serious attempts on their own. That's what the studies show. They have gone to a commercial program like Weight Watchers, Jenny Craig, whatever. They've gone to lesser comprehensive programs than mine, and then they end up on my doorstep. And this has been going on for 30, 40 years. So by the time they get to me mentally, and everybody's telling them, you fat, lazy bum, or whatever you are, and they think themselves that they just, it's so the psychological piece, to your point, Dr. Bay, is key. We have to rebuild their confidence. We have to rebuild that they can do it. They have to, because otherwise they feel defeated before they even start. Why? Because they tried it many times and they always failed. They've always gained the weight back. So what is going to make this time any different? And that's why we start with obesity is not your fault. It is not a willpower disease. It has to do with a set point in your brain, these hormones in your gut and your metabolism, and we know how to address it. And when I approach it with the very first visit that way, they're like, Doc, sign me up. Where do we go from here?
I hear you. I hear you. Dr. Aluya, you have a question. Go ahead. You're muted, Dr. Aluya. Come off of mute.
Yes, so it's a question and a thought process, and at the same time, um, some analysis as well. Obesity, weight, and the disease that we face today is very complex. And when you talk about people and human beings and everything else, there are multi layers to it. And I must thank Dr. Hunt for doing such an immense and incredible work on what you do. And I wish, you could, I don't know, maybe we'll clone you, AI may help down the road, so that whatever you do, if we can't clone you, then we can create an avatar of you that will speak like you, in other places. Because the beauty of where we live now, we must understand AI and then with the face of generative AI. But in the future, I talk about the things that are going to come. It's called immersive AI, where you get immersed into AI, and then it truly will become functional to you. That's when AI becomes truly your personal assistant. Now, when it comes to the whole gamut and the whole process of everything else, and weights and all that, yes, obesity is not your fault. True, it's a reset of what's happening in the brain on a daily basis. I was just talking to my friend yesterday who looked at my niece who just got into NYU, and she's like, oh my gosh, she looks like a model and all that. She's put something else. I said yes, but you can't believe when she was much smaller. She was a plumpy baby. She was really big. I thought she would grow up becoming big, but today she's a model size person. So things do change, and our brain change with it. Now the question is this: is it just the brain, or is it also just the GI too? Because it's a combination of multiple things. You talked about ghrelin. We also talk about leptin. Ghrelin is the hunger. What do you call it?
Hormone.
Hormone, and leptin is the satiety hormone. And of course, you talk about the sleep hormone, which is what do you call it? The one we give on tablets.
Melatonin.
what?
Melatonin.
Melatonin, right. So
Mhm.
all of those three things, form together. Ghrelin produced in the stomach, melatonin, in our brain, and is metabolized in the liver. All of this is your whole mixture of all. Now, but guess what? As human beings, we've evolved from where we were, from plant eaters to meat eaters, and to where now we consume what? Refined sugar. And we know that obesity truly became a big issue in the United States um, in the late 1980s,
Correct.
where, as we talked about before, when the government decide to say, oh, they told this, the tobacco company that, hey, you know what, tobacco is bad for you. It's causes cancer and all that. So what did they do? They redirected all the scientists that were doing studies on tobacco and all that. They redirected them on food and nutrition, basically. And that's why eventually we saw what we have now, the refined sugar, fructose, high fructose, and all that and all that. But again, it's all a game of numbers, a game of, 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 of interest, and a game of money. But then it's playing into our brains. So this is where we are now. And how do we begin to mitigate the problems that we're having? Because at the end of it all, it translates to one thing. Are we healthy? Are we not? But if you look in our community, we're getting sicker and sicker every day. I'm sorry, which is a fact. And obesity is doing damage to us. In 2016, the WHO, no, 2016, yeah, WHO and CDC declared diabetes an epidemic. And as at that point in time, there were just about 340 million people living with diabetes in the world, supposedly. Here in the United States, were 29.1 with 88 million pre-diabetic states. Today, it's about 33 million people compared to 2016 to today. Now, globally, as we speak, we have about 540 million people with diabetes. By the year 2030, that number will rise to 700,000. And we know it's going to exceed up to a billion people. But who are these people affected more than anything else? We, especially people of color. And that's why I sound the alarm to those in Africa, because Africa was a continent that was described in the books without diabetes. Today, it's a big issue. Now, America exported sugar and its genes and music and everything else. It also exported obesity around the world. And we've seen all of this. So, looking at the BMI and all the way they define, and maybe the question, one of the questions I'll give to you, your answer is true, is BMI truly mounting or calculating what we have? Knowing that we black folks have a bigger bone structure and all that. And really, BMI started way back in the 1800s and perfected up to 19 or 1970s. Is it still content today? That's one question for you. But before you take other questions, I'll ask other questions as well. If you look at obesity in this country, in the 1960s, 13% of adults were obese. 70s, it went up to 15%. And the 80s went up to 30. By the year 2000, there was just about, I think, 40%, no, 30% of people who are obese in this country. Today, it's about 41% obese adults. Now, if you look at our community, black community, we have always been bigger. And that's where the number of obesity and whatever. Today, we have about 50% of us black who are obese. Now, that translates to disease. We talk about diabetes. We talk about kidney diseases. We talk about heart diseases. We talk about hypercholesterolemia and all that and all that. Now, if you look at blacks who are here, we have blacks here in the US, but guess what? We also have blacks in Africa. What's the difference between blacks in the US and blacks in Africa? One thing, food and what we eat. And they always say, you are what you eat. Dr. Bay has said it multiple times here, which is a fact. We are what we eat. And if you look at the diabetes numbers I just said, because our food changed. You understand? So how do we, first of all, go back to getting just not just in our heads and our mind and all those do those fancy stuff that we do, but also making it simple and, like you talk about, strategic and easy, where we'll now go back to eating regular food.
Mhm.
Somebody did a study a few years ago, and took the average. They did a GI. This is Dr. Dr. Maza. They did endoscopy, took a biopsy of the GI tract of an African American here in the US. This was done in the late 1990s. And then took the same biopsy of an African, right? And of course, you and I know that the GI tract today of an African American is so much blunted as compared to that of an African. So what they did, they changed the diet 6 months after. And guess what? The GI tract of the African now became blunted, and the GI tract of the African American became more, convoluted just because of the diet alone. So we must, in our community, as we speak and talk to people, we need to go back to eating more fiber, more grains, more greens, and all that and all that. And that's where advocacy comes up. When you talk about, I think Dr. Our big brother, the surgeon, had said something earlier on, where you talk about the social, economic, and policy aspect of it. If you look at our community, we have multiple bodegas and all those things that are selling those foods there. Maybe the advocacy in that respect, so that we save more people from diabetes and all the complications of it, by saying, hey, you know what? Let's speak to our mayors. You can no longer have 3 or 4 bodegas within a 2-lane block. You understand? Because in certain cities, there are edits, you can't get more than certain alcohol licenses within a certain block. Maybe that's where we can begin from. So that all these bodegas and the kind of food that they sell maybe now be different. We can also say, you know what, the food stamp that we're getting, you can no longer buy refined sugar with it. You have to buy regular foods. Another aspect is say, you know what, for you who sell soda and all those food, we need you to set up at least one food market in a certain town. These are the things and steps that as physicians and advocates will begin to look at, so that we'll keep our homes and our community healthy. Thank you.
Excellent. Let me. Oh, you always end us up, but we're not through yet. We have several things, but you always have excellent excellent things to say, Dr. Louis. There were a couple questions, and I think we covered all of them. And there were the last two I want to make sure that we get. Let's not. This one comes from Sharon B. Let's not sideline menopause causing a lot of negative metabolic effects, especially weight, insulin resistance. So as far as menopause is concerned, Patrick, do you have anything to say as far as that's concerned from a GYN perspective?
Well, I think part of it is, it's a conundrum, right? Because the menarcheal hormones, these are steroid hormones, which in effect are diabetogenic, right? So when you see these hormones go up when women are pregnant, hence you see diabetes increasing in pregnant, at least insulin resistance do. Mm-hmm. So then what changes during menopause, right? During menopause, these hormones are not present. So what replaces them? And I do believe that other stress steroids replace them from the physiologic perspective of dealing with the side effect of the lack of these hormones, right? So the urinary dysfunction, the vasomotor symptoms, these are stressful symptoms. So you may see more cortisol levels going up, right? And those hormone levels, I presume has similar diabetogenic effects. Now, also with menopause comes, one of the issues that we talk about tend to come with decreased activity, right? Because as you age, the orthopedic issues come about, the sleep deprivation comes about. So oftentimes people are more tired at times during the day when they're usually not, and hence their physical activity decreases. So again, it's not necessarily the direct effect of menopause, but some of the lifestyle adjustments that have occurred as a result of menopause.
Mm-hmm. Excellent. There's another one, and Dr. Hunt.
Dr. Bay, let me add a little bit to that. And thank you, Dr. Anderson. I was involved. I was called one time to come give a talk on the women's conference, and we talked about,
Mhm.
the process of menopause and all that. And I've always said, and I've written about it as well, some article, that menopause, I'm sorry to say, and I'll use this word, is one of the most dangerous periods of a woman's life. It is. Because at that point in time, a whole lot of things are changing. And that's the
Mhm.
reason why, you know, um, after menopause, you find out that an increased risk of arthritis, increases of everything else, including coronary artery disease, big time. Because what's happening at that level, where they get hot, they get cold, and all the other stuff, it's inflammation. I've measured a few um, women who go through menopause, and on the average, when people come to see me on the average, I do the ESR and CRP, and I just measure. And one of the things I noticed that in our community, on the average, a lot of people's ESR are the 45 and above, and some of
Mhm.
them 70, 80. And I said, do you feel anything? No, I'm good. But the CRP is usually low. CRP is the acute inflammatory marker, and ESR is the chronic inflammatory marker if there's something chronic going on. On an average basis, everybody's ESR should not be more than 15. But in our community, I've noticed 45 and above consistently. And then if you check the vitamin D level, it's usually very low.
Mhm.
And if you check the A1C, is usually very high at the same time. So, and I've done it. I give them vitamin D, boom, the inflammatory state comes down. And at that level, where women are in the menopause area as well, the ESR consistently stays 55 and above. And that's where inflammation is a big issue. Inflammation everywhere, including the vessels of the heart. And that's
Mhm.
why within that period, before you know it, heart attack takes place. So,
Mhm.
and I know Dr. Anderson had just was throwing references to it, the cortisone and all that. I think, human beings as well at that period, there's an auto regulation where it shuts down certain blood flow to the adrenals, especially you have the three layers, the androgen formation aspect of it. So if the normal hormones are not being produced, the sex hormones, the byproducts are sent up to the mineralocorticoid section of it, and that is ramped up, and that's why that inflammation takes place.
Yeah.
So, and in my other stuff, in my other world, and some of the things I've done, I try to overload the system, and that's why one of the things I've used is some of the things I encourage people. I use omega rather than using what do you call it, OCPs, oral contraceptives, that some people use with the hot flashes, because it increase the risk of strokes, increase the risk of blood clots and all that. So omega has really been really good with that, and I'm sure Dr. Hunt, please look into that and see how it works. I have some experience in that. But then that's the reason why when women are at that level, it's a very dangerous time, and they need to go seek help. Really sit with their primary doctor, come up with a plan on how to manage that, including checking their diabetes level, checking risk for cholesterol, checking risk for everything, because after that comes really problems, arthritis
Mhm.
and everything else. You know.
Yeah, and I also think that there are many folks in our society who, kind of embrace the aging aspect of it and consciously, for lack of a better term, take themselves out of circulation per se. They kind of adjust their lifestyle, become less active, less engaged, less motivated. Um, and as providers, we need to not just, encourage people to survive illnesses, but to thrive through some of these illnesses, of which weight loss is important, because one of my philosophy is, I think, in people who practice geriatric medicine should find a way to get some of these patients physical therapy for weeks at a time out of the year, because then they become, as part of the aging mantra, they become more and more sedentary, and what happens with that? Muscle atrophy, tendons fibrose, and that limits their activity.
Mhm. We've actually run out of time, but we're going to extend it just a little. There are questions here that I just wanted to, and they're simple questions. We're going to keep the answers short. All right. One says steel cut oatmeal with berries is my go-to breakfast. Is that still okay? So steel cut oatmeal, Dr. Hunt. It's a fun little
Steel
question.
cut oatmeals is better than instant oatmeal. Again, always better than what? But if you pulled the grain out of the ground and desiccated it yourself, that's even better. But steel cut oatmeal is probably the best oatmeal, I guess is my
Okay.
answer.
All right. Another one is Dr. Hunt recommends decreased carbohydrates. Does this include complex carbohydrates?
So when you say complex carbohydrates, you mean, I'm assuming, fiber type carb. So there are um, um, complex or not complex, and so the um the complex ones are like the fibers, and I don't mean that. I don't mean fiber. I mean the um 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 refined carb. So technically it's refined, and then unrefined means complex. So the refined carbohydrates, the ones that are desiccated, that means that are chopped up, bread, rice, pasta, potatoes, those are the refined carbohydrates. The unrefined carbohydrates are the fibers that are not desiccated or chopped up.
All righty.
But also, Dr. Hunt, if you might comment on the simpler sugars, like, we advocate fruits, but sometimes that gets translated into juices, right? You eat whole fruits, you're eating fiber with it, and you have this fructose, which is even a simpler carbohydrate than your breads, right? And then instead of eating the orange, now we go for the orange juice, which lacks the fiber.
So yeah, so that's a very good point. The further down the chain you get, the worse off it is, because it gets absorbed much quicker, and it impacts or hits your liver even much harder. And so the more complex it is, the less damage it does. So your point is well taken, Dr.
Yeah. Yeah. Um, Dr. Hunt, before we let you go, as I stated, I had several Facebook friends, even before we came on, wanted to know your how to contact you. So if you could, anyone who needs a pencil, I give you a moment to grab a pencil and paper, so Dr. Hunt can give you some information as to how to contact him at his office, or maybe however you want to be contacted. But that's important. So give
Yeah.
you a moment.
So so I will start by saying that I don't have an avatar, and my practice is pretty busy, and I don't have and so the waits are very long. So you would have to be patient with me because I don't have an avatar. And and if I give you the number and they tell you, a long wait, do not just be but that's why I wrote a book about it. I wrote a book about
and,
it.
and before you're off, I'm gonna bring your book up as well. So we're gonna
Okay,
do that too.
but
I just want to get
anyway, my
the
number
address.
is at Penn Medicine, Princeton Health. The number is 609-853-7272.
Can you repeat that, please?
609-853-7272.
Yeah. So yeah, I'm gonna bring up your book here. Let's see if I can do this cleverly. Uh, all right, I'm gonna share this. Can everyone see that?
Yeah.
All righty, all righty. So your book is out there, and it is you know the no guesswork diet. I got to be honest, I haven't read it as of yet, but I will get it, and I think that I'm just so proud of you for what you do, and what you've been doing all these years. I've been following you, and brother, you're doing it a lot. You're doing a lot, and we appreciate you
Thank you.
110%.
Thank you.
So yeah, man, yeah. Uh, it's so nice
Well,
that
it's interesting. I'm looking at the picture in the book, and even though it is geared to weight loss, this is kind of the image of how I tell my cancer patient that they ought to be eating. A diet that has all the colors, rich in micronutrients, what I call nutrient dense diet.
Yeah. Oh yeah. Oh yeah. Definitely. So
Yes.
the
That
thing,
was a purposeful picture. I purposely picked that picture.
yeah, yeah. I mean, you're doing a great job, brother, and we love to even have you back in the future. You know what I
Okay.
mean, and to hit some other aspects because there's so much to this. Believe me, I have a list of questions that I didn't even get near. They didn't come near. So we got to get you back and talk. And I know you're busy. I just like to make you busier. You know the deal. So
Yes, sir.
it's all good. I appreciate you. I appreciate all three of you brothers. You know, we had Sam on,
Yeah, he told
Samson
me.
Davis, and he
Hmm.
was excellent as usual talking about the prostate. So, you know, we just appreciate all you guys are doing
Thank you.
for our
Thank you.
community, for our people, and you know the strong, you know, positive image that you're portraying. We just love it, man. We love it. So
And,
thank
and
you
I and
very
I
much for all of that.
and I just wanted to say that thank you everybody on here. I am I'm I've been busy, but this is such a great platform, and all everybody just I learned so much from you guys. So thank you so much, because I learned so much from everybody on here. So I appreciate it. So thank you for this platform, Dr. Bay. I really appreciate it.
All right,
No,
thank
I
you.
know the engagement is great because we not only get together on this platform, Dr. Ali, Dr. Bay, we even travel do mission trips together. We have one coming up, and I always look forward to hanging out with Dr. Ali to see how he's going to modify the next the next colonoscope to scope someone in a place where we don't need enough good electricity.
Oh
There you
wow.
go. There
When
you
there's
go.
a will, there's a way.
Yeah,
I'm
yeah.
telling you, this engagement is so positive, and for the young people who want to get into medicine, it's not so much about you know earning a living or gaining wealth. It's all about the relationships. I mean, Dr. Luya and I, we do so much out in the community, and we walk out into the supermarket, and people will know me. Say, "Oh, by the way, are you one of those three doctors?" And I said, "I know."
Oh yeah. Oh
Your
yeah.
foundation
Definitely.
is
I
one of
know.
the
I've
topics
always
that's
wondered which one of
pervasive.
them I look like because they ask
You
me
must
all
look
the
like
time.
me. I
There
think
you
it's
go.
me.
You met him today.
I really think so now. I need to meet up with you. We'll take a picture every time I get kicked off.
Oh, that is so great. That is so
Of
great.
color, Indian, Black, and Latino, who ever existed because of these three guys and this book and this foundation. Are you one of the three doctors? No, I'm just one of a few.
Excellent. Excellent. All righty, guys. All right. But I must admit, we are going on a medical mission to Guyana. The last week in October, Dr. Ali, Dr. Anderson, myself will be there, and it is an awesome mission. Dr. Court, who was on earlier, he is our he's our leader, you know what I mean? And he's been doing this for what, 25 years or something like that.
At
And
least, yes.
we go there and we see patients, you tell you. So one more year, we're going to Guyana to do our medical mission. It's just what we do. All righty. So
And Dr. Bay, I'm going to add to that. We're doing one more new thing this year in our mission. We are going to be teaching, we're going to be doing some medical lectures for continuing medical education across Guyana on an online platform. So while we're there, we're going to have 3 medical lectures that are going to be given by specialists for
oh,
teaching and engagement across the
you
country.
didn't ask me. You didn't ask me.
Oh,
Yeah.
I will
So
be.
please send the link. Send the link.
I was told I need to do some Guyana cases in Georgetown University Hospital.
Wow. Send the link. Let's share.
All righty, all right. This
Definitely.
is so great. This is so great. It just tells you that, you know, there are a lot of people out there that want, you know, blacks or I should say people of African descent to do better. And this is one platform that we're going to keep it going. I don't care. I'm going to jump up and down until somebody listens because, you know, it's necessary. We have a responsibility to our people. So thank you very much. Let me close it out. Thank you for OB Healthy for letting us bring this platform. I mean, without them, obviously, this would not happen. Believe me, it would not happen. We're here every second Saturday at 1 o'clock. And please, you know, let others know it's a Zoom. And please, um, you know, just remember that 1 o'clock Saturday, you're going to be where you're going to be. It's about caring and sharing, all right, and let others know. Most important thing that I can say is please do not change any aspect of your medical care until you consult your physician. Only your doctor, your personal doctor, can truly take care of you from a medical standpoint. All right. If you've missed the YouTube, please just go on to OBHealthy, hit the doctor sign. You'll see a little camera there. Hit that camera. All of our past webinars come up. Okay. And I look forward to seeing, oh, not even seeing, but I look forward to everyone who's on joining next time, next month. And listen, all I got to tell you is, and you know our culture, all I got to tell you is spread the word. Okay. Just spread the word what we're doing here. Until next month, I'm going to say peace to everybody. Thank you, all you physicians. You know I love each and every one of you, and I appreciate what you do. And I look forward to having everybody here back next month. Take care, everyone. Peace.
Good seeing you, Dr. Ali.
Peace. Nice meeting everybody.
Peace now.